Hi, I'm Maggie Calkins, and I head up Ideas, Innovative Designs and Environments for an Aging Society.
Maggie, you've been working in this field for a long time, and actually that's one of the reasons why we wanted to interview you. And I when I studied sociology with Robert Merton, he had a term which was on the shoulder of giants. And what we realized is that no matter what you're doing, there's a history to it. Was there a giant on whose work you relied or you based your initial work when you started in this field many years ago?
Yes, absolutely. That would be Powell Lawton, who was a clinical psychologist who in the 1970s opened up the first dedicated memory care living area in a nursing home in the U.S. and broke all the rules for how we do nursing homes. But it was his theories that really resonated with me, and he had a model that suggested that people with lower competencies, which certainly individuals who are living with dementia are in that category, are more impacted by their environment, physical and social, than people who have higher competencies who are better able to deal with different kinds of stressors in the environment.
When you say impacted, is that negative? Is that positive? Is that both? What do you mean by impacted?
It's both. It's how they can both interpret and respond to what is going on in their environment and how they can function and how they feel. It relates to both what they're capable of doing, but also their well-being and quality of life.
What was Powell's model called, and sort of what did it look like?
It's the competence-press model, and he developed it with Lucille Nahimo, and it's a really elegant model that accommodates a very wide range of factors, ranging from socioeconomic status to physical function to cognitive ability or disability.
And really, what it says, if I remember it correctly, correct me if I'm wrong, that the ability that somebody has to deal with the stresses of the environment need to be accommodated in that environment within a narrow range. Is that it, or how would you explain that?
It's that people with lower competencies can deal with less stressors in the environment and can have a narrower band of environmental press that they can manage. So you take someone who is, a healthy teenager who is highly competent and physically able, and all of a sudden they break a leg or break both legs, and their ability to function independently is really reduced. Now, the environment can make it easier for them to function by having curb cuts and automatic doors that open, or it can create barriers. And so that's really what the model was designed to do, was to be able to look at what are both the facilitators and the barriers in the environment that can impact how effective and successfully someone can function.
So what you're really saying is that no matter what the person's abilities, they should be able to function as well as somebody with greater abilities if the stressors are less in the environment. So the environment can help someone be more competent.
The environment can help someone function better given what their competencies are. It doesn't mean that everyone can reach the same level. There are, if you are using a wheelchair and are non-weight bearing, then there are certain things in the environment that you just can't do. But it doesn't mean that you should not be able to get to the same places using elevators and ramps that someone else can, who has use of their legs.
So you helped design one of the groundbreaking environments or places the Corinne Dolan Center when you were working on your PhD, I think it was. In that, you took a specific view towards how to put hypotheses into the environment. Could you explain that and describe some of those hypotheses?
It was actually between my master's and my PhD program, and I really took the theories that Powell had been putting together and made them much more concrete. So as we were designing the Corinne Dolan Center, we knew we wanted to do environmental research. So we designed in hypotheses and ways of modifying the environment so that we could test some of these theories. So we know that individuals with dementia lose their ability to remember, rely on a cognitive map to find destinations. And so the theory was that if you have greater visibility to a destination, you're more likely to be able to find it. You don't have to rely on your memory. One of the ways that we interpreted that was in the bedrooms. We made the bathrooms very visible. They were on the outside wall and did not have complete floor-to-wall ceilings and a door that closes. Because once you've got walls and a door, the person has to remember that the toilet is behind a door and know which door it's behind, because bedrooms typically have 2 or 3 doors. There's a door out to the corridor, there's a door to the bathroom, there's a door to the closet.
So this supported their continence.
So by having the toilet be highly visible, it supported the deficit of lack of orientation by making the destination immediately visible.
So really, you did a complex thinking around this. It wasn't just saying, let's look at the toilet and they'll get better. What's another one of the innovations you hypothesized about and studied?
So a second one related to orientation that is a common issue in shared residential settings is being able to find your own bedroom independently. By definition, in these care communities, you have multiple bedroom entrances that tend to all look the same. And so we put in a display case at the bedroom entrance, and as far as I know, we were the first ones to do that.
And what was in the display case?
So we had residents put their own personal items that had some significance to them, things that they could still recognize. So for some people, it may have been a wedding picture. For some people, it may have been a bowling trophy. For somebody else, it might have been a picture from their childhood. But we worked to make sure that it was items, multiple items, that people could recognize.
So they had a choice of what they put in there.
They had a choice of what they put in there, and we wanted to have a mixture of both two-dimensional, like photographs, and three-dimensional objects. And then what we did is we tested whether or not they helped people find their bedrooms independently. And so for 2 weeks, we asked people, when they had their own items in the display case, to take us to their bedroom and show us where their bedroom was. And we timed how long it took, and we timed how many errors they made. And in general, what we found was that for the highest functioning residents in this building, they didn't really need the display cases that much because they were still able to create a cognitive map. They knew that their bedroom was the second to the last on the left side. For people who were in the middle stages of dementia, it made a huge difference, both in terms of success in finding their room and in finding their room faster when they had their own items in the display case.
So the physical environment, in this case, that you tested out approaches to the physical environment that supported the principles and theories that you were working with, that you had worked on and developed with from Powell's work. What's the third one? Because I remember there was one that had to do with the outside.
We knew that individuals living with dementia in shared residential settings often didn't have a lot of access to outside spaces, and that many care communities were beginning to just lock the door because it was unsafe for them to go outside unaccompanied because they could get lost. They wouldn't find their way back to the building. So for 2 weeks, we locked the doors in the building. We made sure that we did an outside activity every day. So the residents were getting outside, but could only do it when we were doing a scheduled activity. And then for 2 weeks, we unlocked the doors again and let the residents go outside whenever they wanted. When the doors were locked, within 6 or 8 hours, the agitation and distress level of the building just started skyrocketing. They'd go to a door and they'd push on it and it would be locked, and then they'd look around and they'd go to another door and it would be locked, and then they'd go to some other residents and they'd say, you know, they've locked the doors. They've locked us in here. And you'd get 2 or 3 residents going from door to door, pounding on them, trying to get out. It was the worst 2 weeks in that building that we had ever had.
So when you unlocked the doors, they obviously opened them and went outside, right?
When we unlocked the doors, sometimes they would go out and go outside, but I was really amazed at the number of times they would go up to the door and push the door and go, oh, okay. They didn't necessarily want to go outside, but they wanted to know that they could go outside. They didn't want to be locked in. They understood that locking people in is what we do to prisoners, and they were not prisoners. They did not think of themselves that way.
You said you were amazed. Was that like a wow moment?
It was a real aha moment, because prior to that, this was at a time when we were developing special care units because people with dementia had unique needs and they were different from the rest of us. And that was the moment when I really said, wow, they're not so different from us. I would not want to be in a locked building where I didn't know that I could leave, even if I was just leaving to go to an outside courtyard anytime I wanted. These are people who are just like me. They just look at things differently. They're processing some things differently, but they're still people first. And I think that's, for me, the genesis of the movement from special care units for people who are different to taking all of those therapeutic goals and principles that we had been developing based on initially the work of Powell Lawton and turning it into the person-centered care movement, because privacy and orientation and engagement and meaningful relationships are important to everyone to everyone, but particularly to people in a shared residential setting, not just people living with dementia.
So how would you define person-centered care?
Person-centered care is an approach to healthcare that recognizes that the person is at the center and has the right to be making important decisions about their life and their care. And you can only, as a healthcare provider, get good information from them if you know how to communicate effectively with them. And part of the basis of effective communication is having a relationship with the person. When you're meeting somebody for the first time, you don't tend to have deep, meaningful conversations. But if you are with the same caregiver or a caregiver team over time, they get to know you, you get to know them, there's a comfort level. It's, when a mother knows that her child is getting sick before they really have any symptoms, but they just know something's different. You see that with caregivers and individuals with dementia who often can't say, I'm in pain, I don't feel quite right, something isn't right, but the caregivers get to know them.
How does the physical environment design support what you just said, person-centered care? If we wanted to say to the world, you need environments that support person-centered care, what are 3 or 4 elements that you would immediately say provide that support?
So the first is, the first 2 are related items. One is you want to recreate a sense of home. People want to live at home or at a place where they feel at home, and connected with that is scale. You don't feel at home when you're living with 30 or 40 or 60 people. 10 and 12 are the numbers that are tossed about right now as being the most appropriate household size. There are some communities that are doing larger, and in some countries they say 10 is too big, you need to have 6. I mean, that's a real family size unit. So it's the scale of the space, it's making it have the places that a house has. So you have, private bedroom with a private bathroom, and a living room and a dining room and a kitchen and an outside space that you can get to. And then on the social part of it, the social organization part, is having staff who are consistently assigned so that you get that deep knowing between all of the individuals who live in this house. The way you have when you live at home, you know your family better than anybody else.
If you were to say, after starting at a National Science Foundation meeting in 1985, which was some time ago, that today we're talking about a World Alzheimer's Report about the stuff that you began way back then, what is the big message that you would like? What's a poster that you would like to have hanging in every designer's office, operator's office, developer's office? What would it say?
I think it would reflect the shift in our thinking from deficit-based thinking to strength-based thinking. When we started in this field 35 years ago, we talked about wandering and agitation and aggression and disruptive behaviors, and all of the assessment tools that were developed were trying to assess those, and less of those negative behaviors was the goal. And with this shift to person-centered care, the goal has got to be beyond the absence of the negative. It needs to be in the positive realm. It has to be well-being and quality of life and joy. Everybody should experience joy every day. And you get that when people are balanced and feel that they have self-worth and that they have autonomy and the ability to make decisions about their life. Even if you need to put some parameters around that, which we sometimes do with individuals who are living with dementia, working on what are the things that really bring those positive moments of joy to individuals on a daily basis is where we need to be focusing more of our efforts on.
Maggie, thank you very much. And I'll get a poster up that says joy. And that we need that every day. And thank you so much for providing your insight to this important report and this important moment in the world of design for dementia.
Thank you, John. I appreciate talking with you.